Namaste everyone. I'm Dr. Rupesh Karn and I'm back with yet another episode of Medical Detective Series. A woman is referred with fatigue, body aches, and ANA titer of 1:1280. The immediate concern is lupus, and honestly, with a result this striking, many of us would feel the same diagnostic pull. But this case is about what happens when one impressive laboratory test starts controlling the entire clinical story. The ANA was real and it was very high, but the final diagnosis was not lupus. Here is the referral label: possible SLE. The reason is straightforward. ANA is 1:1280 with a homogeneous pattern. Before I reveal anything else, ask yourself, if this patient arrived in your clinic, what diagnosis would be at the top of your mind? And more importantly, what evidence would you require before actually calling it lupus? The central question in this episode is whether a very high ANA automatically indicates a systemic autoimmune disease or whether it can be pointing us towards another organ or another disease process. Our patient is a 48-year-old woman, a school teacher from an urban area. She was referred because of fatigue, generalized body aches, and an ANA of 1:1280. The initial label was possible SLE. Notice that at this stage, we have a test result and two non-specific symptoms, but we do not yet have a defined clinical syndrome. Her fatigue had been present for 8 months and occurred on most days. Generalized body aches had continued for 6 months. For 3 months, she had noticed a dull discomfort in the right upper quadrant. She had also gained approximately 8 kilograms over 3 years. None of these symptoms should be dismissed, but none is specific for lupus. The gradual weight gain and right upper quadrant discomfort may eventually become more informative than the symptom that initially triggered the ANA test. Let us characterize the body aches rather than simply accepting the word arthralgia. The discomfort involved the shoulders, back, thighs, and knees. There was no objective joint swelling, no prolonged morning stiffness, no proximal muscle weakness, and no dark urine following exertion. She had no fever, no unintentional weight loss, so these aches were not behaving like inflammatory polyarthritis and they were not behaving like inflammatory myopathy. This is our first diagnostic pivot. The presence of body ache does not itself create a rheumatologic syndrome. We must define the quality of the symptom before linking it to an antibody result. Now we deliberately search for a systemic autoimmune phenotype. She had no photosensitive or Miller rash, no recurrent oral or nasal ulcers, no Raynaud phenomenon, and no inflammatory polyarthritis. There was no pleuritic chest pain, pericarditic pain, or unexplained dyspnea. She reported no frothy urine, hematuria, facial swelling, or pedal edema. There was no seizure, psychosis, focal neurological deficit, persistent Zika symptoms, or skin tightening. A high ANA deserves attention, but ANA needs a compatible clinical context. At this point, the antibody is impressive, while the syndrome required for lupus or another CTD is conspicuously absent. We now open a second diagnostic pathway. She had type 2 diabetes, hypertension, hypertriglyceridemia, central weight gain, and a sedentary lifestyle. She denied regular or binge alcohol consumption. There was no transfusion history, tattooing, intravenous drug use, or known viral hepatitis exposure. We also reviewed medicines and toxins that may produce liver injury or an autoimmune-like picture. There was no history of nitrofurantoin, minocycline, methyl-dopa, isoniazid, high-dose paracetamol, herbal remedies, or weight loss supplements. This history shifts attention from purely rheumatological problem towards metabolic liver disease, while still keeping autoimmune hepatitis in the differential. The examination gave us objective evidence. Her BMI was 31.6 kg per square meter, waist circumference was 98 centimeters, and blood pressure was 138/86. Acanthosis nigricans was present, supporting insulin resistance. The liver was palpable about 2 centimeters below right costal margin and felt smooth. There was no ascites or tenderness, Equally important, there was no rash, synovitis, edema, jaundice, muscle weakness, spider angioma, or pulmonary erythema. The examination therefore points more strongly towards metabolic disease with mild hepatomegaly than towards an active inflammatory multisystem disorder. Let us compress the case into one useful sentence. This is a 48-year-old woman with obesity, central adiposity, diabetes, hypertension, presenting with chronic fatigue, non-inflammatory body aches, mild hepatomegaly, and who has ANA of 1:1280 but no convincing systemic autoimmune phenotype. There are now two convincing signals, a very high ANA and a strong metabolic liver signal. Our job is not to choose more dramatic signal. Our job is to resolve the conflict using objective evidence. The initial organ screen is reassuring. Hemoglobin is 13.1 gram per deciliter. Total leukocyte count 6,800. Platelets 232,000. Creatinine 0.76 milligrams per deciliter. Urine protein is negative and there is no active urinary sediment. Creatine kinase is 82 units per liter. In other words, there is no cytopenia, no renal dysfunction, nephritic urine, significant proteinuria, or biochemical myositis. These tests do not independently exclude lupus, but in a patient without compatible phenotype, they make active systemic lupus, lupus nephritis, and inflammatory myopathy substantially less likely. The liver profile now becomes central. ALT is 132, AST 88, and GGT 91 units per liter. Bilirubin is normal at 0.8, albumin is 4.1, and INR is 1.0. This is an aminotransferase predominant pattern with preserved synthetic function. The metabolic profile is also abnormal. HbA1c is 7.8%, TZ 312, SDL 34, and LDL 126 mg per deciliter. So we are not looking at an isolated incidental ultrasound finding. We have biochemical liver injury occurring in a patient with multiple cardiometabolic risk factors. And now we return to the result that created the referral, ANA of 1:1280 homogeneous pattern. Does this prove lupus? No. It proves the antinuclear antibodies were detected at a high dilution. A high titer increases clinical interest, but it does not identify the underlying syndrome. ANA can occur in systemic autoimmune disease, autoimmune liver disease, infections, malignancy, drug exposure, and in individuals without a defined autoimmune disorder. The correct question is never simply, is the ANA positive? The correct question is, does this patient have a clinical disease that this ANA result actually supports? The systemic autoimmune evaluation provides no additional support for lupus or another connective tissue disease. Anti-dsDNA is negative. The ENA profile with anti-Smith is negative. Complement levels are normal. The direct antiglobulin test is negative and urine protein creatinine ratio is normal. These negative tests must not be interpreted mechanically because clinical diagnosis is not simply a checklist. However, when they are combined with the complete absence of a lupus phenotype, the connective tissue disease branch becomes weak. The patient has a positive ANA, but she does not currently have evidence of SLE, Sjogren's disease, MCDD, systemic sclerosis, or immune complex nephritis. We must still take autoimmune hepatitis seriously because high ANA and aminotransferase elevation can occur in AIH. Total IgG is normal, anti-smooth muscle antibody, anti-LKM1, and anti-SLA are negative. Anti-mitochondrial antibody is negative, and IgM is normal. These results make autoimmune hepatitis and primary biliary cholangitis less likely, but ANA alone neither confirms nor excludes AIH. The diagnosis of autoimmune hepatitis requires integration of the biochemical pattern IgG, disease-associated antibodies, exclusion of competing causes, and histology when uncertainty remains. This is why the correct response to a high ANA is not to ignore it, but to investigate it in the right organ-specific framework. Other important causes of persistent liver enzyme elevation were assessed. All the tests, all the markers displayed on the screen were negative. But I want to stress on the fact that not every patient needs every test. Tailor the workup to age, pattern, severity, persistence, and local prevalence. Ultrasonography shows mild hepatomegaly and moderate hepatic steatosis, without ascites, splenomegaly, biliary obstruction, or other features of portal hypertension. The FIB-4 score is approximately 1.6, which is indeterminate in this age group and therefore cannot confidently rule out clinically important fibrosis. Transient elastography shows a liver stiffness of 7.1 kilopascals with no evidence of advanced fibrosis. The teaching point is that ultrasound confirms steatosis, but it does not reliably state fibrosis, and routine liver enzymes alone cannot tell us how much fibrosis is present. Patients with metabolic liver disease require a structured fibrosis risk assessment. Now let us rank the differential rather than merely list it. SLE or another CTD is weak because the phenotype is absent, TSDNA and ENA are negative, complements are normal, and there is no renal, hematologic, cutaneous, or articular inflammation. Autoimmune hepatitis remains possible because of the high ANA and hepatic enzyme pattern, but it is unsupported by normal IgG and negative ASAMA, LKM, and SLA. While a strong metabolic alternative is present, MAS LD with MAS is strongly supported by imaging confirmed steatosis, obesity, diabetes, hypertension, dyslipidemia, and aminotransferase elevation. PBC or an overlap syndrome is weak because there is no cholestatic pattern and AMA is negative. Viral, drug-induced, and selected hereditary causes are also not supported. At this point, MAS is leading, but the high ANA leaves enough uncertainty that we must resolve the AIH question properly. Why proceed to liver biopsy? Not because every patient with positive ANA requires biopsy. In this case, aminotransferases had remained elevated for more than 6 months. The ANA was very high, the initial fibrosis score was indeterminate, and we still had to distinguish MAS from autoimmune hepatitis. That distinction matters because the treatment directions are completely different. Missing AIH may allow progressive inflammatory liver injury, while incorrectly prescribing corticosteroids for MAS may worsen weight, diabetes, blood pressure, and metabolic risk. Biopsy was therefore used to settle a clinically meaningful conflict, not merely to explain an antibody result. Now the histology provides the decisive evidence. There is macrovascular steatosis, hepatocyte ballooning, mild lobular inflammation, and mild zone 3 perisinusoidal fibrosis. These findings support metabolic dysfunction-associated steatohepatitis. What is absent is equally important. There is no significant interface hepatitis, no plasma cell-rich portal infiltrate, no hepatocyte rosetting, and no florid duct lesion. The pathologic impression is MAS with mild fibrosis. The biopsy does not support autoimmune hepatitis. So, the very high ANA was not analytically false, but it was not evidence of the disease that had been assumed from the referral label. The final diagnosis now is biopsy confirmed metabolic dysfunction associated steatohepatitis with mild fibrosis associated with high titer ANA. Her relevant comorbidities are obesity with central adiposity, type 2 diabetes, hypertriglyceridemia, and hypertension. She has ANA of 1:1280 without evidence of SLE or another CTD, and there is no evidence of autoimmune hepatitis. The simplest way to remember the case is this: the ANA was real, but the clinical syndrome was metabolic liver disease. Now the management must target the demonstrated disease, not the antibody. First, explain clearly that a positive ANA does not equal lupus. This reduces anxiety and prevents an inaccurate lifelong label. Second, there is no indication of corticosteroids, azathioprine, mycophenolate, or hydroxychloroquine for an isolated ANA without a corresponding autoimmune disease. Third, address the drivers of MAS. A weight reduction of around 5% can improve steatosis, while larger and sustained loss, often more than 10%, is generally needed for meaningful improvement in steatohepatitis and fibrosis. Combine progressive aerobic and resistance activity with dietary intervention. Optimize diabetes, blood pressure, triglycerides, LDL cholesterol, and overall cardiovascular risk. Follow liver enzymes and metabolic parameters and reassess fibrosis risk periodically. The key principle is simple. Treat the proven pathology, not the most dramatic laboratory number. What might connect non-autoimmune liver injury with ANA formation? Chronic hepatocyte injury may expose intracellular antigens. Oxidative stress from alcohol, tobacco, or metabolic inflammation may alter proteins and amplify immune recognition. Persistent inflammatory signaling may produce broader immune dysregulation and autoantibody formation. In that setting, ANA may function as a biological signal of chronic tissue injury without representing a CTD. The case can be reduced to 5 messages. First, a high ANA is a clue, not a diagnosis. Second, do not diagnose lupus without a compatible clinical phenotype. Third, when high ANA and a normal LFT occur together, evaluate both autoimmune hepatitis and common non-autoimmune liver disease. Fourth, MAS LD, MAS ALD, and other CLDs can coexist with high ANA. Fifth, treat the proven disease rather than the lab number. The next time you see an ANA of 1:640, 1:1280, or even higher without a convincing autoimmune phenotype, remember to look beyond rheumatology and always remember the liver. These are the principal sources supporting the episode. Thank you for watching Medical Detective. If this case changed how you interpret a high ANA result, please share it with a colleague and subscribe for the next clinical mystery. Thank you.